ankylosing spondylitis is a condition that we possibly underdiagnose, all of us. When should we suspect ankylosing spondylitis?
I think even I might paraphrase that we must suspect a spondyloarthritis. Ankylosing is one of the spondyloarthritis. There are many reasons when you suspect. When you have got a male patient, relatively young male rather than a female patient, because spondyloarthritis are more common. When you have a disease which is essentially lower limb involvement rather than upper limb and lower limb involvement. When you have a disease which is more large joints than small joints of the hands. And when there is an asymmetry, you think it might be spondyloarthritis. With that, if there are mucous membrane things, skin manifestation, obviously it adds weightage to your diagnosis. And if in such a patient, if you have got low back pain, then obviously you are thinking in terms of a likely ankylosing spondylitis. Because a lot of ankylosing spondylitis also have peripheral arthritis. There are other features also which I am not telling you, but the reason, other way when the patient for the first time comes with ankylosing spondylitis, low backache, then it has to be persistent low back lasting for say 6 weeks or more than that, which is inflammatory in nature, unlike a mechanical pain. And there are certain very important differences. A mechanical pain is reduced by rest. So when the patient gets up in the morning, he is generally at his best. And as the day wears off, as he is working, the pain increases and he has to take rest, or he or she. On the other hand, inflammatory backache is worse with rest, as happens with stiffness that you get in inflammatory arthritis. So the patient gets up with a very stiff back. In fact, very characteristic, the patient says that he wakes up at night with a backache, and it is very difficult for a patient to turn from side to side. If any patient tells you that I wake up at night with a very stiff, painful back, I cannot turn, do think in terms of ankylosing spondylitis. And if you find bilateral sacroiliac involvement, then what should you do? Do not rely on X-rays to make that diagnosis. X-rays take a few years to be positive for ankylosing spondylitis. If you can, and the patient can afford, possibly more sensitive to read an MRI. But that's what will pick up very early ankylosing spondylitis. All inflammatory low back pain, do not forget tuberculosis and other diseases. It might look exactly like that.
MRI would pick up that too. And HLA-V27 would do and all.
Yeah, it is like rheumatoid factor. Whenever you have a disease, then you think of it.
Greater sensitivity or sensitivity of HLA-V27 than rheumatoid factor?
It is like this. There is, I don't know how many of you have heard of the Bayesian law. The value of HLA depends on what is your preclinical probability. If the preclinical probability is 10%, even if the HLA is positive, it makes no difference.
Because some percent of the normal population is HLA-V27.
5%. And only 2% of them develop ankylosing.
Yeah.
So that's how it is.
There is just one more question on ankylosing. In ankylosing spondylitis, there is no real disease-modifying therapy. There is some, but no real disease-modifying therapy yet, as in rheumatoid arthritis. And anti-inflammatory therapy is long-term. So, and one area of controversy is the patient to use anti-inflammatory therapy on a regular daily basis or on an SOS basis. Is there any consensus on that?
I think for that, if you are going to treat an ankylosing with NSAIDs alone, today, of course, the biologics are something which the patient can afford or possibly a better choice. But considering that that's possible, not possible, if you are using NSAIDs, I think the NSAIDs have to be used on a long-term basis. Even if now there is a feeling, I think there are one or two papers which suggest that even when the patient does not have pain, it might be a good idea to continue to do this NSAIDs because they seem to prevent damage occurring to the joint. That, of course, is yes and no. But ankylosing patients do require NSAIDs for a very long time. Some of our patients will be taking for years.
This is one area where I think the family physician has to know, though he will not be treating ankylosing spondylitis on a regular basis, but he should not discourage use in this one situation of anti-inflammatory drug use. Like in osteoarthritis, if the patient is taking Bovaran every day, we discourage that. In ankylosing, they probably need to take that every day, and you should not discourage it. Another small question on fibromyalgia. As we all know, fibromyalgia is a disease of women, predominantly a disease of women, predominantly below the age of 55. And they come with spot pains all over the body, and there are characteristic 18 points described in fibromyalgia, which are if tender, they characterize fibromyalgia. It's was considered as a kind of a psychosomatic illness like irritable bowel syndrome. Your take on the etiology of fibromyalgia, something new has come, and about the treatment of fibromyalgia.
The first question is simple to answer. We don't know what this is. Really, as yet also we do not understand what exactly is fibromyalgia, etc. Very briefly, what happens is that we say there is a plasticity of the central nervous system towards pain. What we mean is that how we react to pain depends on how your brain gets conditioned to reacting to pain. Put it in a very simplistic way. I sort of give a simple example. If I pat him on the back and if he's my friend, it's a nice thing. If he's my enemy, then he will be angry with me. That pat would not be accepted. So that's the plasticity.
Relativity.
That's the plasticity. So what is happening is in these patients, they seem to overreact to painful stimuli. There are ascending pathways, there are descending pathways, and the descending pathways which inhibit response to pain get dysfunctional. And that's why the patient sort of, and then it is like that macro, this thing, when you go on increasing the loudness, like or when you drop a pebble in water, the circles go on increasing. So every insult of pain only magnifies the response. So at a point comes where even simple things possible to see pain. That's so possibly how the whole disease develops. For some odd reason, every point in the body does not pain. In fact, if you place them here, just below the elbow or the lateral epicondyle about 2 centimeters, 3 centimeters down, expressive pain. There is you do that. When you place here, nothing happens. So the pain is very selective. A patient who is painful everywhere is not fibromyalgia by definition. Fibromyalgia patients have those very typical pains. Again, don't ask me why only those localized pains. And the amount of pressure you put down, because you could really press so hard that you will get pain anywhere in the body, is to press sufficient to blanch your nail. That's the pressure. You know you have to put adequate pressure, and that produces unbearable pain. So it is really a maladjusted or plasticity modified CNS response to pain. It's
the treatment of fibromyalgia involves giving drugs which are also used, as we all know, for painful neuropathies. Drugs like amitriptyline, pregabalin, gabapentin, etc. What do you use?
You see, we also believe that one of the things that goes wrong with patients with fibromyalgia syndrome is poor sleep. They really have a very disturbed sleep, so that when they get up in the morning, they are not fresh. One of the things that you ask me, when you wake up, you feel, day has come, let me do something. So because of that quality of sleep which is changed, so we tend to use drastic antidepressants as the first choice, because that seems to set the rhythm back. Except when the dose again is not what the psychiatrist uses, which puts the patient to sleep. Is the dose which does put the patient to sleep but wakes him up in the morning fresh. So it's a very small dose, it's not with 10, 20 milligrams, possibly don't last 25 to 50 milligrams. That's about that.